at the computer writing something.
I'll grab it.
All right. Great, thank you. Thanks for having me here today. And it's a pleasure to be here. Just a couple of disclosures. I know so much about failed bone grafts that they asked me to teach you all I know about failure. And I have, unfortunately, no other disclosures. So I don't get paid by anybody. You know, the alveolar cleft bone graft, we've been doing this for about 110 years now. It was first described by Lexer. 1908, and for about 50 years there wasn't much in the literature about it at all. We really didn't think about when we were doing it, how we were doing it. But in general, you know, our goals are a united and symmetric maxilla, close the oronasal fistula, provide bony support for dentition, and to provide bony support to the upper lip and the base of the nose. You know, this is from an ASMS study here a few years ago. Just in general, what we do, he looked at 240 programs, surveyed them across the country. A huge number actually responded. That was pretty good. Most of us do this based on the eruption of the canine. Most of us do it secondarily. For most programs, that is in the 6 to 9 years of age range, with a smaller minority at the 10 to 12, and then it drops off earlier or later than that. Most of us use iliac crest for our donor site, and most of us don't do routine follow-up imaging. Only about 6% of us use a grading system to assess take. So, you know, when we look at success, and this is a, never mind the busy table, but this is from a review, a systematic review we did recently looking at age and bone graft success. And if you look at the success rates of these different papers, it's anywhere from 55 to 100%. And 100% is always, you know, tough to believe in any study, and 55 seems a bit high. But if you look at the overall success of alveolar cleft bone grafting, it's in the high 80s to at least the mid 90s for most studies. Well, what does success mean for alveolar cleft bone grafting? You know, we just talked about what our goals were, but if you look at a lot of the literature, they actually rarely mention those goals. What they mention is what the bony retention is, and you'll see a lot of different scales used in the various studies. You have the Berglund, which is in the upper left there, the Chelsea, which is kind of a modification of that. Lang had this really complicated one they described. Hines at the bottom said, well, we need to look not just at the cemento-enamel junction area, but the apical part of the teeth. We lose bone there. There's the Kinderlin, which just looks at a percentage take. So there are a lot of different ways we look at or describe success in the literature of bone graft. There's also now more recently using CT volumetric analysis. And if you compare that to you know, plain X-ray and two-dimensional analysis of the bone, you'll see that there's about a plus or minus 20% accuracy if you look at CT volume. But that's obviously a little bit better, more accurate way of looking at whether or not our bone retention was good. But what you see, you know, if you look at these studies, and you see, well, a year we had this much bone, or we had this much. If you follow things out a little further, and Feidinger did that in this study in 2007. They did one study in 2006, and they looked at a year retention, and then they followed it out a little further because they were kind of surprised to see that, well, you lose a lot of bone after the first year, and you know, that's not too surprising. And if you really consider this, you put this bone in there, and if it's you know, if it's not doing anything, this is just Wolff's law in action. You know, Wolff's law says bone will adapt to the loads under which it is placed. You know, if you put bone in there and it's needed, it's going to stay. And if you look at some of the other studies with retention of volume, if you look at the canine erupting into that space, the retention is much better. But I can tell you, that's one of my patients right there. If I put bone in those gaps right there, it is not going to be there in 2 years, unless something else goes in there. So, you know, when we think about success and you know, how do we avoid failures, I think it really comes down to a lot of planning with your orthodontist. You know, just in terms of technique. You know, meticulous technique, making sure you get a very secure closure on the nose. Joe or Steve was just talking about that, getting a secure closure on the palate, getting good soft tissue coverage. Antibiotics, you know, these are all part of our routines. The papers actually don't talk about these things very much, but obviously those things are very important. Where's my, I think this is not the latest version. Anyway, I had a picture, you know, when you look in the books, when you're looking at alveolar cleft bone grafts in the textbooks and you're learning this, you see this really neat picture of a palate that has this little teeny alveolar cleft right at the ridge. When you start doing these, you know, this is, hopefully you don't see this too much, but you get in the operating room and you're looking at this alveolar cleft that looks nothing like that nice little neat cleft you see in the book. When I get in the operating room and I see that nice little neat cleft that looks like a textbook, I know it's going to be a good day and we're going to get out of there on time. When I walk in and I drop my sound in and that sound goes all the way back, you know, halfway to the soft palate, then I know it's not going to be a very fun day. And when I got about 7, 8 years into my practice and I started seeing some of my kids back for bone grafts that were now my own patients, I realized, wow, I was not paying enough attention to the alveolar ridge when I was doing my palate repairs. And you really, at the time of palate closure, and this kiddo's that way not because of that, he's for other reasons, but at the time of palate closure, you really need to make sure that that mucosal closure, that periosteal closure is as far anterior and as secure as you can get it, and you're going to be loving yourself when it comes time to do the bone graft. So, you know, all those things aside, technique, you know, antibiotics, the papers don't talk much about antibiotics. It's pretty routine for us to use antibiotics for about a week afterward. A couple years ago, I decided to do, cut back on antibiotic use. We're not using as much for implants anymore. I thought, well, maybe this one perioperative dose would be enough. I called that the summer of lost bone grafts. By the time I realized it and started using it again, we lost a lot of bone grafts that summer, and I could, you know, walk into the room post-op and there was that odor, and I knew we had lost the bone graft, or at least some of it. And so, you know, in my mind, antibiotics are particularly important along with technique. But I'm not going to talk quite as much about that right now. I think really what it comes down to in terms of success of your bone grafts is timing with your orthodontist. If you look at bone volume retention and making a plan with your orthodontist, not only the timing, but what is the ultimate plan for that patient. If you look at bone retention, when the tooth is moved into that gap within a good time frame, there's great bony retention. If it just sits there for a while and you're going to do an implant rehabilitation of that area, you're going to lose some bone. You're probably going to have to regraft it. So in my mind, you know, is success some X-ray measurement? Is it some CT volume? In my mind, if we got through this and I don't have to regraft them for anything and I didn't compromise my final result, that is a success. There's the slide I was looking for. You know, is every complication you have a failure? No, you know, this was a nice study out just a couple of years ago from Sweden. They looked at success and failure based on the Bergman criteria, and they actually had equal representation of sequestra and dehiscence in some of their failures and successes. So just because you have you know, a little bit of exposure a couple of weeks on or something like that, that does not mean that's going to be a failed bone graft. You need to keep them on their soft diet, keep them on some extra antibiotics, keep them doing antiseptic oral rinses, but that doesn't necessarily mean a failure. So, what do you do when you get the failure? You did everything you knew how to do, you did your technique right, you put them on antibiotics. You know, what do you do now? Well, I can tell you, again, the time to avoid failure was when you did your primary closure, in my mind, you know, or your palate. The more work you do then to set yourself up, the more successful you're going to be. But that's not where you are now. Now you're at the time of failure. You know, there aren't a lot of data about revision bone grafting. We talk a lot about the success rates, and they're actually pretty good, but there are very few papers actually out there about revisions. This was one paper I found out of Vanderbilt, just looking at their revision rate. It looked actually kind of high to me, 18% for unilaterals and 32% for bilaterals. Given the success rate we quote for all those other papers, it seems a little bit surprising to me that the revision rate is so high. But again, I think that speaks to the fact that what we use as measures of success for a lot of those papers is not necessarily what our long-term measure of success is. I think those bony measurements we can take in CT volumetric analysis are useful for trying to do studies and determine what factors would lead to initial excellent graft take. But long term, they don't necessarily correlate with whether or not those patients need to be revised. This is a paper from Joe and Anand recently, and they, what do they do when they have a failed bone graft? They looked at actually 3 different groups, and I just put a table up here from one of them because the point of their paper was you can use allograft very successfully in these patients. They had 3 groups. They looked at allograft or autograft for revising bone grafts, or autograft plus allograft and allograft alone, and they were wishing to avoid the donor site or morbidity. And they found that actually allograft alone, if you already have some bony bridge in there and you have a good setup, is going to be pretty successful. This was the study from Jeff and Mark and Jeff Amuda, looking at actually primary bone graft using demineralized bone matrix and BMP. But one of the groups they actually included was that green bar you see in the center, and the bar you see in the center of the other, at the Berglund graph over there. And that was salvage bone grafts. And they actually had very nice success using demineralized bone matrix and BMP for salvage grafting. And one of their points was, our rate of salvage grafting with BMP and demineralized bone matrix is actually as good or better than primary iliac crest bone grafting. And so it's probably a good choice for secondary revisional grafting if you need to do it. That is an off-label use. I've gone back and forth on that one myself a little bit. There are some studies that show an increased risk of cancer and spinal surgery using that, and I've had some orthodontists approach me and say, you're going to put BMP in a child's mouth. I will say the studies are pretty mixed. Some of them show there's no association, some of them show it's dose dependent, some of them show it's not. But just to throw that out there if you're considering demineralized bone matrix. Another possibility is bone marrow mononuclear cells combined with tricalcium phosphate. This was recently described in a Nature Scientific Reports article with pretty good success, equal to iliac crest bone graft. So that's a possibility. And then I found this one, which was very interesting in response, Joe, to your paper. Cord blood is what we need. We all know that cord blood has stem cells in it. This editorial said so. We need to just put cord blood in our alveolar clefts when we revise them. Unfortunately, I didn't keep any of mine, and I'm not sure anyone does, so I'm not sure we're going to get that. At our program, what we do though, if we need to revise, I just go back to the other hip and I use bone graft, and that's been our standard. I think though, just getting back to the time of primary graft, and I think it applies to when you're doing a secondary graft as well, the most important thing you can do is pick up the phone and talk to your orthodontist, have a plan. What's the long-term plan for this area? We can get bone to take in just about anything early on, but if there's no plan to move a tooth into that area anytime soon, or there's no plan to put an implant in, then maybe the right answer is just wait, and wait till right before those things happen, because Wolff's Law prevails. If you put bone there and it works, 3 years later it may not be there. And if the plan for dental rehabilitation is not for a few years down the road, then let's consider waiting. Unless you're at risk for losing a tooth. That's my one big question. Are we going to lose a tooth adjacent to the cleft if I don't regraft this, or if I don't graft it right now? And if that's the answer, then I think we need to go in there. And this goes right along with standardizing your protocols. This is a study out of Scotland. They did a retrospective review of their bone grafting. At one point in the course of this history, they started standardizing everything, and their success rates went from 58 to 76% by the criteria they were using, which just goes to show, and there are studies that say even if you standardize to an imperfect protocol, you will get improved results. So working with your orthodontist, coming up with a standard that you and he or she both agree on, so you can kind of work automatically, but communicating in every case I think is extremely important. I'm just going to skip over that one. remember Wolff's Law, and I think those are the keys to success.
Thank you, Steve. That was a great talk, and I agree. I don't think there's another operational, orthognathic included, that we depend so much on the orthodontist. You know, so much is dependent on the timing and orthodontic preparation for the success of bone graft. And once you miss that boat, it just becomes a very route to go. Next we have Dr. Lynn, Dr. Kent Lynn. Nice Ohio Valley welcome. Thank you. Here in Lexington. He'll be talking about another difficult problem, which is a very protuberant maxilla.
Good morning. It's sort of interesting that that I look back at my career, and somewhere along the way I became one of the older people instead of one of the younger people. But it's interesting that, and I want to share some of the wisdom that I've sort of gathered over those years. It is interesting that, you know, Steve Buckman and Jack Yu and Arun Hussain and Frank Pepe and I were all residents together, and kind of how we've grown up together and learned together and evolved together. And that's really one of the beauties of what we do, is that, you know, we develop these lifelong friends. And as long as you kind of stay honest with each other, it's a wonderful opportunity to learn and reflect with each other. So I'm going to, I was given this topic, the premaxillary setback, and I put revisited because this is not a new concept. So as was already spoken about, the problem is the flyaway or excessively protrusive premaxilla, and this becomes a significant obstacle for the surgical closure of the lip. So this painting hangs where I went to school at the University of Pennsylvania. It's the Agnew Clinic by Akins. And this is kind of how I think we all learned. You know, there's the master surgeon who's sitting there and telling you, you know, this is how you do it, and this is why you should do it, and there's no other way to do it. And of course, I've had my fair share of those type of professors. I learned how to do my clefts with Peter Randall and Don LaRosa and Milt Edgerton and a lot of those people that you've heard talk about today. So basically, I would warn you that dogma is something that you need to be very careful about. And the definition, of course, is it's a prescribed doctrine complaint is unquestionably true by a particular group or person. So one of the take-home messages that I want to give the younger people in this group is that you should always question these thoughts. So whenever it comes to clefts, I always kind of start to think about, you know, where we've been in order to know where we're going. And this gentleman here, I don't know how many of you recognize him, but this is Ralph Millard. And Ralph, of course, has been one of the giants in the field of cleft surgery. And so one of the resources that I always use when I try to learn a little bit about some of these things is his massive tome called Cleft Craft. And this is the volume that's involved with the bilateral, which is basically what we're going to talk about, the bilateral cleft of the palate. So, you know, he's very eloquent, and he says, without a shadow of doubt, the ominous shadow cast by the projecting premaxilla is the #1 problem in cleft lip and palate surgery today. And I think when you encounter one of these, you will wholeheartedly agree with him. So, you know, if you look at his book, chapter 3 is what to do or not to do about the projecting premaxilla. And for those of you who can see, there's basically the premaxilla is projecting, and you have 4 arms. You have excision, you have the external manipulation or traction, you have the closure of the lip, and you can do it, and then you have the setback. So clearly this is not a new concept, but you know, one of the dogmas that I was taught is you should never do that, because you will create growth disturbance, you will create problems that would be something that will haunt you down the road. So that is, with that sort of background, and again, these are the solutions when you see somebody who has one of those excessively protruded premaxilla. Well, I think everybody would agree that you would never want to resect, and that was done in the past, but I think that has definitely been ruled out. So orthopedic manipulation is definitely something that lots of teams and lots of practitioners rely on. and then I'm just going to quickly review what are the surgical options. So everybody has seen this, the orthopedic manipulations, the taping, the elastic bands, doing a dental facial device such as the Latham, and then of course the NAM. Now I do want to echo what's already been said here, and that is that these type of surgeries cannot be taken care of or done without a team effort. And not having an orthodontist who's able to do a NAM puts you at a significant disadvantage, in my opinion. I had not, in the 27 years that I was at UVA, we did not have somebody who would be willing to do NAM, and that was a real problem. And that kind of led me down this road that I'm going to talk about. But I think that NAM, if you have NAM, it is a very, very helpful adjunct to your treatments. So, what are the surgical options? Well, you can do a lip adhesion, you can do staged repair, or you can do the premaxillary setback. So, in my opinion, these are the indications for doing premaxillary setback. If your manipulation is either unavailable, unsuccessful, or unattainable, all right? So you have nobody to do it, or if you do it and the patient is non-compliant, or for whatever reason, it's just not able to get that premaxillary segment back, then I would urge you to consider doing this premaxillary manipulation. Of course, you can always do, you know, staged lip repairs or adhesions and all that, but I think that the premaxillary manipulation is a very, very useful tool. And the second indication, I think, is a previous attempt at bilateral clip closure, and it fails. So in some ways, this talk is going to be a little bit confessional because, again, I had not considered doing this until I had some problems with my follow-up and with failure of bilateral closures. And again, I always think that if anybody tells you they have no complications, it's probably because they're not really operating